Very good presentation. Definitely ICG is going to be the way forward. But for the study purpose, I will ask few things. One disadvantage, you don't have a control arm.
Yes, sir.
During the study period, were there cases done without ICG?
No, sir. Mostly all cases were done with ICG.
Okay, so your endpoint is basically anastomotic leak rate.
Anastomotic leak rate.
And you evaluated only patients with symptoms of suggestive.
Symptomatic anastomotic leak.
Then that can be kept as an endpoint because you are not evaluating in all patients anastomotic leak rate. So you cannot confirm the subclinical leaks will be there, mostly there. And what is the, if in routinely done cases, how many percentage of the cases you have to transect the proximal margin, even ICG is not used in open or lab? Do you have the data for that?
Usually ours, we go.
Do you have the data, any retrospective data available with you, the previous done studies?
Anastomotic leak rate.
Without ICG also transecting the proximal when the viability is doubtful.
Revision of the margin.
Yeah.
Revision, anastomotic leak rate is around 8%, sir. Revision per se, there is no specific.
So if you had a control arm like that also, it would have been better.
So did you revise any omental segment which is attached to the bowel apart from the colonic segments?
Bowel.
Based on the, sometimes ICG shows the surrounding attached to omentum is avascular. So
No, sir.
no such incidents. Okay. So have you adopted ICG based assessment as the protocol in your institute?
Now we have adopted, sir.
So are you using an open ICG system or laparoscopic system?
Laparoscopic system. But for both open and lab, we use the NAR camera of lab.
Lab. So how do you use lab camera for open assessment?
Once we have done the surgery and full part, and then we usually ask the anesthetist to give IV injection, and then we bring that lab set and see it.
So you keep the specimen outside and see?
Yeah.
That may not be fully accurate because there is a separate open system for open assessment. Okay.
Today we are going to delve in the critical area of cancer surgery. Surgery and its effect of cell-free DNA and DNA integrity index in colon cancer. Cell-free DNA is a genetic treasure trove and it is secreted by both the normal cells and the tumor cells, whereas circulating tumor DNA is secreted by the tumor cells alone. Cell-free DNA comes from both the apoptosis and necrosis, whereas circulating tumor DNA comes from necrosis alone. Thus, the fragment size of circulating tumor DNA is longer, whereas the cell-free DNA containing both the apoptotic and necrotic cells will have a variable base fragment, and thus there comes the role of DNA integrity index, which divides the longer fragments by the shorter fragments. While doing the review of literature, I came across very few studies which we had compared the cell-free DNA amongst the cancer patients. Most of the studies had compared the cell-free DNA between the cancer patients with healthy or the patients having some benign pathologies, not among the cancer patients. The various factors which affect the cell-free DNA levels are age, comorbidities, habits, staging, pathological high-risk features, whether they are present or absent, post-op complications, and interval between surgery and the sample collection. Because the cell-free DNA can also be increased by the trauma of the surgery. My primary objective was to assess the level of cell-free DNA at baseline and after surgery. My secondary objective included the clinical and tumor-related factors, deciding the baseline cell-free DNA and DNA integrity index, and to compare their value with the CEA in response to surgery. It was a prospective study, and my last patient recruited was on 15th March 2024. I had collected 10 ml blood preoperatively and 4 weeks post-surgery in EDTA vials, and the sample underwent qualitative real-time PCR, and the DNA integrity index we calculated using 394 base pair amplicons of beta-actin gene divided by the 99 base pair amplicons of the beta-actin gene. I had included patients, non-metastatic colonic cancer patients who are undergoing primary surgery, and we had excluded patients who are having second malignancy or any chronic diseases like CAD, CLD, CKD, or any autoimmune diseases, because all these factors will affect the level of cfDNA in the patient. The statistical analysis was done using SPSS version 20. So coming to the results, we had a total of 40 patients, and the mean age of the patients was 62.15 years, and most of the patients were more than 60 years, around 55%, and 60 and less than 60 were 45%. Comorbidities in the form of hypertension, diabetes were seen in around 30 patients, and the most common presentation was bleeding PR, followed by constipation. As the most common site of cancer in our study was sigmoid colon, followed by right colon and transverse colon. Out of the 40 patients, 10 patients underwent laparoscopic surgery, 29 patients underwent open surgery, and 1 patient had to be converted from lap to open because of the intraoperative bleeding. And in the post-operative period, most patients had normal post-operative stay of around 27 patients, and in 2 patients we had Clevin-Dindu score of 3, and in 1 patient we had a Clevin-Dindu score of 4. Coming to the TNM staging, the most common T stage was T3, and the most common N stage was N0. But the overall staging most common was stage 3 because of the nodal status. And in the high-risk features, around 36 out of 40 patients had high-risk features in the form of CEA, pre-op CEA more than 5, lymphovascular invasion, PNI, and poorly differentiated. Only 2 patients had poorly differentiated tumor. Coming to the results, as we can see, only 21 patients showed fall in the cfDNA in the postoperative period, whereas 19 patients had increase in their cfDNA levels. And to mind, 3 patients out of these 20 which showed rise had recurrence. In the DNA integrity index, both 20 patients showed fall and 20 patients showed rise. And in 1 patient, we could not detect the DNA integrity index preoperatively. On the right side of the screen, we can see the pre and postoperative median values. As the range was very variable, we had used median instead of mean. And the preoperative median value was 24.2, and the postoperative was 29.6 for the cfDNA. And for the DNA integrity index, it was 1.1 preoperatively and 1 postoperatively. And the difference was not significant. Only 3 patients had recurrence during the course of follow-up. So what we did next, we tried to find whether cfDNA or DNA integrity index can be used to predict the recurrence. Thus, ROC curve was calculated, and we found that DNA integrity index cutoff value was 1.5, cfDNA was 275. As we can see from the ROC curve, the highest area under the curve is when we had used cfDNA and DNA integrity index together, followed by the combined cfDNA, DNA integrity index, and CEA together. And the least was when we had used DNA integrity index. We can see the sensitivity and specificity in this table. The cfDNA sensitivity is 66.67, and when combined with the DNA integrity index, the sensitivity becomes 100, and the specificity is 78.38, which falls when we combine it with CEA values. The specificity comes down to 72.97. And on the right side of the screen, we can see the difference in the pre and postoperative value when we did a paired t-test. The values were significant only in the lab versus open and high-risk features in the cfDNA part, and in DNA integrity index, only lab versus open was significant. And for the cutoff value when did the paired t-test, in cfDNA, the lab versus open was only significant, and DNA integrity index, we didn't find any value which was significant. So to conclude, the levels of cfDNA remains high even after surgery, which says that there is some residual tumor at the cellular level even after when we achieve R0 resection, and which is a harbinger of systemic disease. So we need to develop further systemic therapy which can decrease this residual disease, for which we require further prospective studies. Thank you. The limitation of my study is that it is a short cohort and limited follow-up. Thank you.
Very good study. How do you think your finding is going to influence treatment or further research?
So basically, when the CFDNA is even high in the post-operative period, that means that there is some microscopic disease which is still remnant in the patient. Because the 3 patients which we had recurrences in our follow, 2 of them had received chemotherapy, standard chemotherapy. Even after that, they had recurred. So that means that some amount of microscopic disease is still persistent, for which we may need to add some more chemotherapeutic agents, maybe in the form of immune checkpoint inhibitors or some other form.
Very good study.
Thank you, sir.
What's the approximate cost of doing this?
Sir, for per patient, it costed about 7,200 rupees.
7,200 only.
Yes, sir.
And I think in your objective you mentioned CE and CFDNA correlation.
Yes, sir. Yes, sir.
But you didn't show any.
Sir, in the end, I had calculated ROC curve was made, and that ROC curve, when we had added CEA values to the combined effect of cell-free DNA and DNA integrity index, the value of specificity comes down. And the value of CEA separately also we have calculated using the ROC curve, which was 4. So we had...
My question is, did you evaluate independently? Because if the patient with the CEA raised, we know that some form of disease is there. And did that correlate with CFDNA?
Sir, it did not correlate.
You evaluated like that?
Yes, sir. Yes, sir. We have evaluated.
And what metastatic workup you did for this patient?
So generally in the metastatic workup, we do a standard CT thorax. Like in the abdomen pelvis, we are already doing a CCT abdomen pelvis, and CT thorax only we do, along with CA values.
And non-metastatic were excluded from the study?
Yes, sir. Yes, sir.
Last question. Is it for colon or rectum? I didn't.
So colon, sir.
Only
colon
for colon.
Primary surgery alone we have taken, sir.
No neoadjuvant.
Yes, sir.
Okay.
Did the CFDNA values correlate with the T stage or end stage of the
Sir, actually there was a variation. In the end stage, it had correlated with the higher end stage. It was correlating. Like it was not significantly correlating, but with N2 stage, the levels were higher. But in T stage, T1 and T2, it showed higher values as compared to T3 and T4. Because most of the patients, like it was not significantly correlating with anything, sir, over there.
Okay, thank you.
I will be presenting my paper presentation on neoadjuvant rectal scores. Neoadjuvant rectal score, a predictor of survival in locally advanced rectal cancer. Introduction. Today, colorectal cancer is the 3rd most common malignancy, and the standard of care is usually in locally advanced cancers is NACTRT or SCRT followed by surgery. However, the endpoint in most of the trials is overall survival, and it is a cumbersome to have a 10-year or 5-year overall survival, and to come to a point of a result is a cumbersome one. So, we have planned to come with a new surrogate marker for that overall survival in the form of NAR score, which is the neoadjuvant rectal score. The neoadjuvant rectal score is 5PN, which PN refers to pathological nodal staging, minus 3 into clinical T staging minus pathological T staging plus 2 plus 12 of the whole square by 9.61. Basically, the NAR score is derived from Valentino nomogram, which the nomogram itself was validated by 5 European trials, and it comprises of 8 variables such as AHX, type of surgery, radiation received, dose received, followed by these 3 pathological nodal stage, clinical T stage and pathological T stage. Out of 8, these 3 variables were taken for the NAR score in view of the point that these variables will have the most impact after neoadjuvant therapy. And these parameters are simple and no additional expense or workup, and this score has been validated in NACBP R04 trial, and they have categorized the overall survival, they have categorized the NAR score into low risk, intermediate risk, high risk in relation with overall survival. NAR score ranges from 0 to 100, and this study has been done in the aim to assess validity in Indian population. So my aim and objectives is to stratify patient into various risk groups based on their NAR score and study the predictive value of NAR score in terms of oncological outcomes. Primary objective is to predict the overall survival, and the secondary objectives include disease-free survival, loco-regional relapse-free interval, distant metastasis-free interval, and clinical pathological determinants in relation with overall survival. Study design, it is an ambidextrous observational study, and the study setting is Department of Surgical Services, Regional Cancer Center, Thiruvananthapuram, and the study population is patients who have undergone post-NACTRT with curative surgery between the period 2010 to 2015, and sample size is 459. These are the patients, and mostly it includes open surgery in form of 80.39, and most of them underwent APR. However, there is a minimal difference, and mostly we have taken most of the patients were T3 and N1 patients, while the pathological T staging it is YPT3 and YPN0. The results. The initial Valentino nomogram initially NSA-BP R0, they have the results in the form of 98% for low risk. In intermediate risk, it was 89% and 68% for high risk. And we have also come up the results in the form of low risk, intermediate risk and high risk category, and most of the people were in intermediate risk, and though the score ranged from 0 to 100 for NAR score, we had the score in the range of 0 to 65, and the mode was 8 and mean was 15.97. And loco-regional free interval was 86.9 months, and distant metastasis free interval was 85.71, disease-free survival was 83.51 months, and overall survival was 89.94. My primary endpoint overall survival, the median follow-up was 90.5 months, and the 7-year survival rate in the form of low risk 87.3%, intermediate risk 78%, high risk 50.8%. Compared to the original study, there was a difference between 10% in each group. As I said earlier, in the low risk it was 98%, and intermediate risk it was 89%, and high risk it was 68% in the original NSA-BP R04 trial. And we had significant p-value for each group. And we have also categorized for DFS, local, regional and distant metastasis into low risk, intermediate risk and high risk group. So though we, CRM and positive lymph node ratio PCR in univariate analysis had an impact on overall survival, in the multivariate analysis, the NAR score overscored the others with significant p-value in determining the survival rate. So we have also come with other parameters. We have also got additional details while doing the study in the form of, we had anastomotic leak of 2.2%, with complete PCR response of 11.1, CRM positivity of 5.4%, adjuvant hemo patients who received were of 97.4%. And the recurrence rate, we were able to find out that loco-regional was 29%, loco-regional plus metastasis was 16%, and the metastasis was 55%. So coming to the conclusion, though NAR score, it is a simple predictor of overall survival, as it doesn't need any additional expense or workup. We can be able to derive from the details which we have, and it can be used for so it can be used as a short-term surrogate marker. And to our knowledge, it is the first study to validate NAR score in Indian population. Higher NAR score means it is a poor prognosis, and the need to intensify systemic therapy is derived. So, thank you, sir.
Good presentation. When was this NAR score first validated?
NSA-BP R04 trial, sir. It was done around 2010, 2005.
Probably I am not much aware. It's more clinical use.
Sir, basically that trial was done to compare infusional 5U versus infusional 5U plus oxaliplatin versus capecitabine versus capecitabine oxaliplatin to find out the impact of NACTRT with one of the agents to find out the overall survival. And they at that time Valentino nomogram was there. That was initially designed to find out the overall survival that time. However, during this trial, they have found that the NAR score to find out to replace to make it as a surrogate marker in terms of overall survival. They have come up with the NAR score and they classified into low, intermediate, and high risk to find out the overall survival.
Understood. So, what are you proposing? The NAR score can be used for what?
Sir, NAR score can be used as a surrogate marker for overall survival, sir. Higher NAR score means poor prognosis, poor overall survival.
No clinical implication, just as a surrogate marker for.
Surrogate marker, sir.
So good study.
Yes.
Congratulations. So how did you determine the clinical T? Because the accuracy of the entire score depends on how clinical T was determined, no?
Yes, sir. Clinical T we were able to do with the MR imaging, sir. And clinical examination and MR imaging, we were able to derive the T score, sir.
But there is a problem with the accuracy of the clinical score. In most studies, shown that there is a high discrepancy rate between the, especially the T2, T3 determination. Then in your series, 97% of patients received adjuvant chemotherapy.
Yes, sir.
So what difference would it have made? Would the NAR score would have made? Already 97% of patients received adjuvant chemotherapy.
Yes, sir. Adjuvant chemotherapy. Sir, NAR score is designed based upon the neoadjuvant therapy, sir. The adjuvant chemotherapy, we have given just the details of how many patients have received, but it is basically based upon the neoadjuvant therapy totally. So, adjuvant chemotherapy doesn't have any effect on NAR score.
Okay, thank you.
Opportunity to present this paper. So my paper is on early versus late stroma reversal after open LAR post NACTRT. And is it a time to change our usual practice? So when I talk about stroma, so basically we're talking something away from our oncological practice. So whenever we do a surgery for rectum post NACTRT, that comes with a bag. There's a baggage that is also a stroma bag. So when we see any patient who is having a stroma bag, that is a planned divergent stroma, and then the patient after completing neoadjuvant treatment will also undergo a planned stroma reversal. So this has a time gap between stroma creation and stroma closure. So this time gap, we are not being affected, but if you think from the patient perspective, how much he is affected is also important. So any divergent stroma which is either planned or being not planned will come up with its own medical complications and surgical complications. And also the patient will have a big psychological impact and quality of life issues because his body figure is disfigured, and also the cost implications he will have to maintain the stroma. So the question comes whether we can do it early reversal so that we can decrease the time gap between the stroma creation and stroma reversal, or we have to go with our usual standard practice to close the stroma after adjuvant treatment. So the early stroma is done before starting adjuvant treatment, and late reversal is done after completion of adjuvant treatment, which can vary from 3 months to 8 months or even a year. So this prospective study was to study the advantages, disadvantages associated with early reversal compared with late reversal in a patient undergoing stroma, which was done as a part of LAR for rectal cancer post NACTRT. So objective of my study was, primary objective was to compare the 30-day morbidity and mortality between early versus late reversal, and secondary objective was to compare the quality of life of patients assessed at 3 separate times. That is, before LAR surgery with divergent stroma, after 1 month of divergent stroma, and after 3 months of divergent stroma. So it was a prospective study conducted at RCC. So inclusion criteria, all patients whose age was less than 70 years who were undergoing LAR with a planned divergent stroma after NACTRT were recruited, and patients who had prior divergent stroma because of obstruction or any other cause were excluded, and patients with significant comorbidities which can affect our post-op usual routine were excluded, and a prolonged recovery after primary surgery beyond 2 weeks were excluded, and a patient undergoing multivascular resection were also excluded. So when the patient comes after surgery to us, after 2 weeks of discharge, we will assess the patient. We assess the patient. Either are they fit for stoma reversal at that point or not. And then the patients were divided into 2 groups, either into early stoma reversal group or late stoma reversal group, which I mean early stoma reversal group, we are doing stoma reversal within 6 weeks of divergent stoma, and late is after completing adjuvant treatment. And quality of life was assessed with using EORTC questionnaire of QLQCR 29 on 3 separate occasions, that is first with before surgery, 1 month after surgery, and 3 months after surgery. This is the questionnaire. So coming to results, we had 92 patients who had undergone LAR after an SCT-RT for rectum, and out of 92 patients, 12 were excluded. 6 were because of the comorbidities, and 6 were because of the prolonged recovery after first surgery. So the final patients which were eligible with study for were 80, out of which 39 were in the early reversal group, and 41 were in the late reversal group. So if we see the data between the 2 groups, early versus late, mean age was comparable. Sex between male and female in the both groups were comparable. Mean distance from the anal verge also was comparable with 4.95 and 4.9 centimeter, and mean CA value after primary surgery also was comparable. Nothing was significant. But when we see the complications between the 2 groups after being undergoing early reversal group or late reversal group, we can see the mean complications in the early reversal group were null. And in late group, we had 7 complications. And if time of reversal is obviously significant because we were reversing within 6 weeks after primary surgery. So it was 42 days in early reversal group, we have done a reversal. And in the other group, it is 252 days after the primary surgery. That is after completing adjuvant treatment. And so the complications we see after 7 patients in the late reversal group, 1 patient had grade 1 complication, which was only nausea, which was settled with medical management. 4 patients had ileus, which was settled with medical management, and 2 patients had grade 3 complications with prolonged ileus, which for which they were being taken for emergency exploratory laparotomy and found to have adhesions. And if you see the statistical difference between the 2 groups in complication part, it was significant with p-value of 0.043. And secondary outcome, we have compared the quality of life at 3 separate intervals, that is 1 month before surgery, after 1 month surgery, and after 3 months. So if you see at 0 and 1, that is baseline after 1 month, the quality of life is same in both the groups. It is better initially, then little bad after 1 month, because they are at the same level. But if you see 3 months after the primary surgery, 1 group had undergone stoma reversal, and one group had still stoma, which was supposed to be reversed after completing adjuvant treatment. So if you see the graph, the quality of life has improved in the third assessment compared to the first assessment in early reversal group, because the patient had undergone early stoma reversal. And also we can see the improvement in the late reversal group compared to the first group, because the patient are used to the stoma and they are getting along with it. So we assessed at 3rd month, there was a significant improvement in the early reversal group, implying that the quality of life of the patients who underwent early reversal was better than that of late reversal. So to conclude, I will say the complications are low in early reversal group, and compared to the late reversal group, the time of reversal is significant, that we are reversing the patient in 42 days of primary surgery, and in the late reversal we are doing it after 250 days. And if you see if the one question which will come to our mind is, if we do a stoma reversal early before adjuvant treatment, can that surgery delay the start of adjuvant treatment? So if you see, the start of adjuvant treatment was not significant between the 2 groups. It was 40 to 56 days in early group, 36 to 48 days in late group. So to conclude, any patient who comes to us after 1 month of stoma, means LAR with divergent stoma, if the patient is having good performance status, no comorbidities, and he has a normal post-operative course with no issues, we should recommend a early stoma reversal than a late stoma reversal. These are my references. Thank you.
This 6 weeks is almost the time of adjuvant, starting the adjuvant treatment.
Yes, sir.
And I think most of the previously published data, early closure is within 2 weeks, 14 days.
Yes, sir.
So why did you choose this early as 6 weeks?
Early we have chosen 6 weeks because after the patient is being discharged, he will come after 2 weeks. And for all patients who are being undergoing stoma reversal, will go under stringent investigation to see about the anastomosis. They have to go under sigmoidoscopy, they have to go under barium enema, they have to take a CEA test. Then the patient will be taken up for stoma reversal. So we need some time to evaluate the anastomosis and then take up for early reversal.
I think as far as I am aware, all this early 2 weeks, they didn't have any type of investigation before going
it is
the
our,
closure.
yes, sir. But it's our protocol that we investigate all
6 week, I don't know, we can consider it as an early closure. Second is, how did you randomize the patient? Is it a randomized or any thing is there? You randomly randomized or?
We have taken, sir. That is one of the limitation of our study.
Could have mentioned that also.
Sir, one more thing, because...
And one more thing, LAR syndrome, have you evaluated this?
No,
patient?
we are not evaluated, sir.
And all patients underwent ileostomy only, no?
Yes, sir.
Transfer report.
That was the inclusion criteria.
Was there any crossover between
No,
the
sir.
arms?
Because when the patient is coming after 1 month of surgery, they are being put into early group or late group. So based on that, they have underwent surgery. So there was no crossover.
Because your assessment is over at 3 months.
Yes, sir.
So that means, don't you think it was slightly unfair to the group who underwent late reversal?
It is unfair, but we need to do that to see if we can do that for the betterment of quality of life for the patient. That is our limitation. We need more data on this to make it standardized, because
Usually, as Dr. Dibin mentioned, early reversal is usually done in the same admission. Before the patient gets discharged from the admission for the primary surgery, usually within a week they do the early reversal and send. Otherwise, good study, congratulations.
Thank you, sir.
Good morning, respected judges and delegates. My study is on the pattern and predictors of D3 lymph node station positivity in patients undergoing curative surgery for adenocarcinoma of the colon. My aim was to obtain regional data on the pattern of apical node station positivity in colon cancer patients undergoing primary surgical treatment at RCC Trivandrum. The primary objective was to determine the prevalence of apical lymph node positivity in patients undergoing surgery for colon cancer with D3 lymphadenectomy, and the secondary objectives were to find out the various factors associated with apical node metastasis, to assess the postoperative complications associated with D3 lymphadenectomy, and to ascertain the incidence of skip metastasis in D3 lymphadenectomy patients. It was a prospective observational study conducted from 31st of August 2022 to 31st of December 2024 at RCC Trivandrum Division of Surgical Oncology. We had calculated a sample size of 120 according to a study by Ishike et al. The inclusion criteria was patients undergoing primary surgery for adenocarcinoma of the colon, and we excluded patients who had metastatic disease and patients who were undergoing total colectomy for synchronous cancers because the lymphatic pathway may be different for both, and for patients who do not undergo D3 dissection due to any technical difficulty or comorbidities, and patients who have previously undergone colonic surgery because that also would have altered the lymphatic pathways. A detailed history of all patients were collected in a proforma, and all the patients underwent standard D3 lymphadenectomy along with colectomy depending upon the tumor location. All the lymphatic tissue that was corresponding to the D3 lymph node station was retrieved and sent separately after grossing the fresh specimen on the side table in the operation theatre. Our primary outcome was the apical node positivity rate, and secondary outcomes were the risk factors for apical node positivity, adequacy of lymph nodes, 30-day postoperative complications, and the rate of skip metastasis to apical nodes. We had a total of 139 patients, of whom 70 were female and 69 were male. The mean age of the population was 62.4 years, ranging from 23 to 85 years. And we had 11 patients in the young age group. Most of them were in the 50 to 80-year age group. The most common site in the study population was sigmoid colon cancers, amounting to around 63% of the entire cohort, and followed by ascending colon and then transverse colon cancers. 23% of the entire patients were operated by laparoscopic approach, and the approach was open in 77% of the patients. We had most of T3 and T2 cancers, which amounted to 64 and 23% of the entire population. 62% patients were node negative, and the rest 40% patients were node positive. In the PT stage, in the P stage, stage 2A was most common, followed by stage 3B and stage 3C. The average total nodal yield was 17.86, ranging from 6 to 36, and the average apical nodal yield was 2.04, ranging from 0 to 11 with a median of 2. There was no nodal tissue present in 19 patients in whom we had dissected and sent out a node, which came as fibrofatty tissue in the final HPR. So the apical node harvest rate was 86.4%. Out of the 139, 10 patients had apical node positivity, amounting to a apical node positivity rate of 7.19%. 2 patients had skip metastasis to apical nodes, which came up to 1.4% in the entire population. And we compared right colon and left colon, mid-transverse colon. 5 of the 10 were from right, and 5 of that were from the left colon. And in our cohort, all the patients who had a T3 primary had apical node positive. There was no nodal positivity noted in T1 or T2 tumors. And clavin into 3A and above complications were there in 7 patients. We did a univariate and multivariate analysis of the factors that may have affected the apical node positivity. We got age less than 45 years, extracapsular spread, lymphovascular invasion, and perineural invasion as significant factors. However, the numbers with the confidence interval was a little wide, but we discussed it with our statistician who said that it is because of the difference in numbers between the two groups when we compared 10 versus 129. We also compared multiple other factors like gender of the patient, grade of the tumor, tumor size, mucinous histology, CA value, and T stage. These did not have a significant association with apical node positivity in our study. So we concluded that the prevalence of apical node positivity in our study was 7.19%. It was low in T1 and T2 tumors. The central extent of nodal dissection for colon cancer needs to be studied further. And currently, we can have a selection of cases where we have to do apical node dissection. The formulation of predictive nomograms, however, may need preoperatively detected factors. Thank you.
Good study, congratulations.
Thank you, sir.
So, in your study, in the preoperative imaging assessment, how many patients had apical node in enlargement?
Sir, in the preoperative assessment, gross enlargement of only the apical node was found in only 3 patients, out of which 2 were the skip metastasis patient we had in the total 10. Those 2 patients had grossly enlarged apical nodes in the preoperative imaging. And 1 more other patient who also had other nodes positive.
So, based on your study, so do you recommend routine apical node dissection?
Yes, sir. 7.19 I feel is still a good percentage for recommending apical node dissection for colon cancer patients routinely.
Was there any specific complications associated with such nodal dissections in your study?
There were no intraoperative complications associated with it, sir. In the postoperative complications, 7 patients had clavin node 3A and above complications, of which 2 were anastomotic leaks, which we have not attributed to the apical node dissection per se.
Any vascular injuries?
No, sir, no vascular injuries in this study subset.
I had 2 questions. My interest is on did the apical node positivity contributed with the alone factor for needing an adjuvant in any of these cases?
Sir, in the 2 patients who had skip nodal metastasis, that came as a factor.
What was the T stage and other?
T3 was the stage, sir.
For that patient?
For the skip metastasis
These 2
patients.
skip patients. And they didn't have any other high risk features?
They didn't have any other high risk
nothing.
features, sir.
And
one patient had LVI.
LVI. And morbidity, did you compare with those with known who didn't undergo?
No, sir. We had
objective was
only
morbidity.
a single arm study, sir.
Do you think frozen section study of pericolic nodes will be helpful to determine whether somebody has to undergo apical node dissection?
Probably,
is it
sir,
going to
but
help?
still it would be a very cumbersome process to dissect the pericolic nodes out of the specimen and send it. And also, in 2 of our cases, we had skip metastasis to the apical nodes.
But those
So again,
patients had a radiologically detected
Yes,
node,
sir.
no? Some attempts been done actually. There are some data from the literature of such studies. Okay.
Thank you, sir.